We're right, girls. So, good morning, everybody. Thank you for coming to this very important discussion. I'm Jocelyn McLean, and I'm going to guide this morning's conversation. So, I'm a registered nurse, and I've worked for many years with mesothelioma and lung cancer patients in my capacity as a lung surgery case manager at RPA in Strathwell Private Hospital. But in June 2014, I came to ADRI on a part-time basis to set up a dedicated support service for patients, carers and families who are living with or who have lived with a diagnosis of pleural mesothelioma. So this position has now expanded to a full-time position in August 2017, and I currently job share this position with Joanne Roseman, who's on our panel. So welcome to the ADRI Mesothelioma Q&A Part 2. Today we're going to explore another difficult part of the mesothelioma journey, the part that patients and families face when treatment stops working. It is a difficult time because disease activity and/or treatment side effects overcome the benefits conventional treatment can offer, and decisions need to be made about ongoing management. This part of the journey is not well talked about, yet the consequence places an enormous physical and emotional burden on the patient, the carer, the family and the loved ones. So we have an hour to canvass issues around minimising symptoms, maximising support, as well as planning for increased care needs until the end of life. We hope that you will learn about the expectations of losing a loved one and take away some practical tips on how to make the expectation a more tolerable reality. In fact, we hope that at the end of this conversation, you might feel more confident to make these difficult subjects part of normal conversation in the future. So to help us do this, we have invited a very informed panel of expert clinicians from across a variety of professional domains. So we welcome Dr. Judith Lacey, Therese Smeal, Fran Ferguson and Joanne Roseman. So I'll start with Dr. Lacey's expertise. So Judith is head of the supportive care and integrative oncology at Chris O'Brien Lifehouse. Her primary interest is in the development and integration of supportive care interventions to keep people living well with cancer, independent of prognosis and stage of disease. Her area of interest is in whole person care, integrating care for people and their families living with cancer or chronic illnesses that affects their physical and emotional well-being. She works with complementary and integrative medicine practitioners, psychologists, other medical specialists, nurses and allied health professionals to maximise patient well-being. As a palliative and supportive care specialist, she has extensive experience in managing cancer pain syndromes, cancer-related fatigue, gastrointestinal and nutritional effects of cancer and treatment-related toxicities. And her research interests and activities are in the field of integrative oncology, medicinal cannabis, supportive care, service developments. So we also have Therese Smeal. Therese is has a long history in working in palliative care and in the Western Sydney in the early 80s. It began, then in Parramatta Hospital, late 80s, saw the funding and development of tertiary level services in Western Sydney increased. The palliative care within Western Sydney began to formally develop. So she started working in community-based specialist palliative care in the 1980s, or late 80s, as a palliative care CNC. So she has many years of experience with the then Sydney Home Nursing. During the mid-80s and early 90s, she completed postgraduate studies at Cumberland College, Health Sciences, and the New South Wales College of Nursing and the Australian Catholic University. She's continued to work in Western Sydney palliative care until 2010, and then Therese accepted a position in the South Western Sydney Local Health District as a palliative care area nurse coordinator. The role encompasses all clinical environments of palliative care nursing across the LHD. So she's involved in the Southwest Sydney local health district with the palliative care home support packages called PEACH program, and has seen great collaboration between hospital and community teams to enable many people to die well supported at home, well supported. And she is the current past president of the Palliative Care New South Wales, the peak body for palliative care within New South Wales. So we'll be picking Teresa's brain, definitely. Fran Ferguson. Fran, I don't actually have a formal bio, but Fran is a rural cancer nurse coordinator from the Central Western Cancer Centre in Orange, and I've known Fran for many, many years, and she's been a great person as a go-to for us here and in my previous role for lung cancer patients and for mesothelioma patients. So we're very keen to hear, Fran, your rural experience. And Joanne works with me. Joanne is a support coordinator here at ADRI. She's worked as a registered nurse since 1980 with a passion for providing holistic care to patients, carers and families. Her background extends from paediatrics to the aged, from critical care to chronic and complex care, cancer therapy and palliative care in the community. Joanne is keen that patients are supported to live well and access any information, equipment and services to stay at home for as long as possible. So with that knowledge and background of our clinical experts, I'd like to just start off with a question that we hear very frequently in the meetings that we have, in the support meetings for patients, carers and families that Jo and I facilitate. And often the statement is something like, the doctor said I have mesothelioma, there is no cure, my survival will be around 8 to 12 months, so get your affairs in order. So I would just like each of the panel to interpret that for us, please. Maybe, Therese, do you want to start?
Okay, I think it must be an enormously impactful statement to have that said to you, perhaps in the, clinical room of a doctor's clinic room, to hear that sort of statement. And I'm not sure what that really means, and it's a common theme that we often hear patients say that, we were told to go home and get our affairs into order, and I would think for most of us, none of us have our affairs in order at any stage of our life fully anyway. And so now we have this huge impact perhaps of a diagnosis that is going to end our lives prematurely, and what does that really mean? And my experience of caring for many people over the years is it's probably the last thing that people need to hear at that time. It's very rare that you're going to walk out of that room and die that night. You've got more chance of being hit over by a bus, I would think. So I personally would just like that comment probably not to be made, and I'm sure that someone like Judith would never use that sort of term. It's often probably used more by our acute care colleagues at times, with maybe just not the understanding of what a huge weight that carries with that statement. So I'm sure we'll unpick it further, but I think just at the beginning to say that it must have a huge impact, and I think deaden a lot of perhaps the really good practical information that may be given to you at that time, but all you will remember are those, 6 or 7 words.
So I've been working in palliative and supportive care now for just over 20 years, which is quite a while. And it's probably, except for the first 10 years of general medicine in my career, it's been most of my career. And working in this space, things have changed a lot over time. And we've reached a point where, although we have a certainty that we can't cure a disease, the prognosis is quite variable. So it's often, and I'm never the first person people will see, so often we'll find that someone with a diagnosis of mesothelioma will be told, this isn't a curative, you can't be cured from this. We're going to offer you treatments to try and keep you as well as possible for as long as possible and control the disease for as long as we are able to do that. But when someone comes out of the room, the thing that they will hear is, I've got 8 to 12 months to live. And we know that is changing, and some people, the prognosis is very short, and some people, depending on the time of their diagnosis and the treatment they've had, may be living for many years with a diagnosis of mesothelioma. So there's this, it's quite a difficult space for people. And so my approach is then to say, well, let's just take it step by step and make every day as good as possible. Make sure that you feel as well as you can be every day. We'll watch out with you to see what happens next and approach that with you. It is really important to speak to your family and discuss the reality of the fact that you are going, this disease is deadly and you are going to die at some stage for many people, not everyone. And that it's always useful to start talking early about advanced care plans and advanced care directives and planning ahead so the burden isn't then on your loved ones to make a decision for you. And so it's a discussion that continues after that whack that's really important with your healthcare professionals. And our job is really about managing every day with you so that your life, so you can live your life to its fullest every day for as long as that may be. So that's how I continue that conversation with patients.
And certainly for a number of our patients, they do get delivered that news, but because I'm also an advocate for people to have open discussions around death and dying, even when they aren't diagnosed with anything, I'm a great advocate for advanced care planning, but more importantly about what someone's wishes are. And so to that then, for our patients and our families, when they get those words and they feel like they have to do their advanced care plan, they've got to get their will done, they have to get all of the paperwork that's involved, it can be really, really overwhelming. Who's going to be the executor? Who's going to be my enduring guardian? Who's going to be the person who's going to make those decisions? What I suggest too is that people don't feel that they have to do it all in one time, because it is exhausting, distressing and overwhelming in a lot of cases. So what I suggest to people, if they do feel that they need to get on top of those kind of issues sooner rather than later, that they really pace it out, that they attack one thing at one time, and anyone who has to deal with Centrelink or any other service provider like that, I suggest they only do that once a week. They make a very large pot of tea, they get themselves very, very comfortable, and they take it very slowly. And once that's done, then they stop, and then they focus on living. That's what the focus is. And then perhaps next week there's the job of, okay, what are my values? What are my wishes? How do I want this to pan out? But taking it slowly, I think, is really important.
And I guess I just agree with everything actually that the other three have said. But going back to that original statement that's so in your face and revolting, I don't know how you guys felt, you know, when you're hit with statements like that. But it's so very important how it's handled. In our team, our doctors tend to always just say that, you know, the disease is incurable, like Judith was saying, and give the patients the option then of whether they want to know the prognosis. We might hold that for a few visits before that terminology comes out, you know, with how long you've got. And also our doctors tend to give the, you know, case of if we had a room full of 100 people with mesothelioma, you know, 10% of them are going to do very well and live for a number of years. Majority, you know, unfortunately just go, you know, they break it down like that. And I don't know whether that's what the patients feel is the best thing, but from my observation, I think it's the best thing, the best way to do it. My cohort of patients often are the country people, you know, like the salt of the earth, the farmers, and I know for a fact that they really like the directness and the honesty that comes with those horrible words right at the start, because at least it gives them the opportunity to get things said, to get things organised, you know, if that's the way they want to go. And most people, I find in my experience, do like that directness and honesty. But yeah, I totally agree with all the other things as well that the other three said.
Thank you. Just as an example of the reality of it, a lady phoned me one morning and she said, Jocelyn, I need to talk to you. She said, I was told I had 8 to 12 months or 8 months to live, and she says, my use-by date is up today. And she says, I feel really well. What's happening? And I said, enjoy it. So it is a real thing that people do, you know, turn over and think about when they're at home. So we're now going to look at, we know that, and Judith alluded to, that mesothelioma behaves in a variety of ways. It can be rapidly aggressive, developing disease, definitely resulting in death within 6 to 12 weeks. It can also be a slow, indolent disease even without treatment. Survival can be 10 plus years. Or for those who have lucky enough to have surgery, we have some long-term survivors up to 14 years. But most patients do survive around or more than 2 years, with or without treatment. So what I'd like to know is, what are the physical indicators that the disease is progressing? So, you know, people have had their treatment, and they're in a sort of an observation period, and then things are starting to not be so well, don't go so well. So what are the physical indicators that the disease is progressing such that the focus moves from active treatment towards palliative treatment?
I'm happy to start because this is quite common. So I guess I'm an advocate for early referral to palliative or supportive care, and that the approach should be that you are being supported from the time of diagnosis. Having said that, as people are living longer and really living well, they really don't find a need to come frequently to those appointments, and so it seemed a waste of resources, but having that connection is helpful. So how do you recognise when there's a change? I think it varies from person to person, but generally it's related to the symptom burden being more significant. And you have to realise that sometimes the symptoms get worse, but it's something that is reversible. So it's always important, if the symptoms are changing, people are becoming more short of breath, or pain is getting worse, or cough is developing, it may be something that is reversible or treatable, like some fluid or intercurrent infection, or something that may be palliated with some radiotherapy or some other treatment. So it's always worthwhile checking in and not assuming that if somebody is getting worsening symptoms, they must be dying. So that I'd like to stay at the beginning. But if that combination of worsening symptoms, weight loss, loss of appetite, loss of energy are symptoms that often come in a cluster, and it's important to then talk to your doctor or your nurse and say, look, I've got all these symptoms, is that what's going on here, and let's check in. And it's often that combination of symptoms that, despite every effort to manage something that is potentially reversible, doesn't improve, and that's a sign that the disease is probably getting worse, and that you need to have more active involvement with those people in your team that can help manage your symptoms more aggressively, and potentially put in more services if that's required. So it's a bit of a dance, and it's a bit of a balance, but it's identifying what's going on, what's reversible, what's not reversible, and these clusters of symptoms that, despite everything we do, are not getting better.
Anybody else like to make a comment?
So just a little more on the symptoms. So as Judith said, weight loss, the big one. Loss of appetite, I think, is one of the biggest symptoms to show disease progression. A lot of mesothelioma patients just struggle all the way through their disease with appetite problems. Excuse me. But loss of appetite, I think, is one of the largest indicators that we might be just having a little moment of trouble there. So always report into your care coordinator or your contact nurse if you have an increase in those symptoms. Some people get a worsening of a cough or a new cough if their disease is progressing. Other people might notice that they're getting some shortness of breath or worsening shortness of breath if the disease is on the move. And the other big symptom for meso would be pain. If you have a change in your pain, it's suddenly getting worse, or you've got a new pain, that they're all worrying signs. So if you get onto your contact nurse or your care coordinator, whoever is your person, that's the step up before you get to your oncologist, they're warning signs that we would act on. So very usually, excuse me, nerves. Very usually we'll bring the scans forward if you have symptoms that we're worried about. And then, you know, once we see what's going on, you'll plan.
While the others here are far more experienced around the symptoms, the other symptom I would always ask that you all remember about is carer distress. You know, whilst obviously the patient is very much front and centre of everyone's care, you know, there are very few patients in this world that don't have a carer, and whilst, you know, you physically as a patient may be relatively stable, if your carer is experiencing, you know, whether that's physical distress in terms of perhaps some of the actual physical burden of care, but more often than not a more emotional distress, that please don't think that, well, you know, Dad or my husband's doing okay at the moment, you know, it's a bit stupid if I'm going to be ringing up the Joannes of the world or the Judiths saying, you know, I need some help. Because if we all can help you very much at the beginning of the journey, that whole journey, I think, is still going to go a lot better if we've got recognising that the carer distress and the burden of care is a really important symptom that we all have a responsibility to look after as well.
I was going to ask you a question on that. Sorry. Do you think carer distress is a sign sometimes that somebody is worsening? Because there's some hell of a stoic bunch of people out there that say, yeah, I'm all right, and the carer's freaking out because, you know, it's harder to get out of bed or harder to get dressed in the morning, which are those subtle symptoms. Do you think that carer distress is a good prognostic, you know, a good tool for us to gauge if someone's deteriorating?
Definitely. We might all think we are experts sitting at this panel, but let me tell you, I think, and I'm sure Judith would agree, and the other girls too, that a carer will know that patient better than anyone for a start. So a carer often has the best barometer for a start. But exactly what Judith says, you know, many of us go into a doctor's appointment in our Sunday best clothes and, yeah, everything's fine, everything's good, because to start to tell you that it's not is perhaps having to really, you know, recognise that I've got something pretty serious happening here. But it's your carer that perhaps doesn't sleep through that, you know, cough that's happening through the night, etc., or the time it takes you now to get perhaps to the bathroom because you're losing a fair bit of muscle mass, because you're far more fatigued, your appetite, your nutrition is not as good. So absolutely, I think it can be on a whole lot of levels that health professionals should always listen to carers. You know, we used to say about paediatrics, you know, that parents were the best indicators of what was wrong with a child. And I think that can be said for all carers, whether it's a physical recognition and, you know, so always feel brave enough to sort of say respectfully to your family member that's the patient, you know, look, I really do need to let the doctor know that, this has been happening now for 3 months. But, that's often driven by fear, I think, that, oh God, if I admit that something's happening, then that's it for me. Whereas we know very clearly often it's not. It's about we need to review that symptom management, we need to maybe up the ante with whatever we're doing, but we're here to ensure that you live as well as possible with your diagnosis. But a carer is incredibly, and it might be multiple carers, and sometimes when you've got 10 carers in your clinic room, you can feel like you're playing the United Nations versus the diplomatic corps. But, seriously, whether it is 10 carers or one carer, and that's not always family, please never discount that your best friend may be your best carer and best advocate, whomever that may be, but very much so.
The only other thing I'd like to add to that is fatigue, that going on from that. And that may not be fatigue for the person who has the disease, but fatigue for the carer. And fatigue is something that a lot of our folk are concerned about and find difficulty in managing. And certainly for carers, again, it's fatigue because they sleep with one eye open and one eye closed. Every time their loved one is up to the bathroom, they're awake. They might be able to go back to sleep, but the carer is generally still awake for 2 hours later. So fatigue is a really big thing, and managing fatigue for not only the patient but also the carer. And that's when I always suggest that if the person who is unwell goes and has a sleep, so does the carer. And then it's about organising extra support services, extra involvement of community or neighbourhood or any other service that we can link in to try and lift some of that load for the carer so that everybody gets a rest. And sometimes, and I've also said that to some of our folk too, about going into hospital or hospice for a couple of days, it's not just for the person who's unwell, it's also sometimes that the carer needs some respite. In fact, the carer needs to go in and have someone, prepare their meals, make their bed, help them in the bathroom because they are beyond exhausted. So carer support to help them look after the person is vitally important.
I think that carers are from day one. I mean, obviously the patient is the person with the illness, but we talk about carers being hypervigilant, and that happens at a very conscious level when we're awake and we're doing whatever we're doing, but it's continually always there. And I think sometimes we need to educate our patients about that you can be having a really good purple patch and be really quite well for 3 or 4 months. Often your carer, your families never forget what that doctor perhaps said 6 months ago. You've actually decided, well, hang it, I'm getting on with my life and I'm going to do it. And, your carers, your family, your friends, always in the back of their heads, so that whole emotional fatigue is there, that the analogy of sleeping with one eye open and one eye shut, your ears are always open, your heart's always open, your soul's always open. So I think it's something that I would hope we do a bit more research in the future about, because there's a lot of it. We think we know so much about life and we don't really know that much at all, and I'm sure in time to come we will learn a lot more about the whole carer complexity.
So when the patient gets to this point where the treatment is, the active treatment is ceasing, or in many cases is still persisting, and the symptoms are developing, and you can, and all these other symptoms that you described are also taking place. So who is the best person to have a conversation with the patient about what it is that they don't recognise that they need, but they do need? Like, is it time to draw back from treatment? Is it time to focus on other aspects of living? Who's the best person and how does that happen?
What an interesting question, because I think what we've realised over time is actually it's the person who has that best good relationship as a health professional. And we always hope it's the oncologist, who has, and I always hope that the oncologist who's involved in the person's active care is the person having that discussion initially, who's seeing that person every few weeks, because a lot of people now are on clinical trials until they die. So there's a lot of, it's shifting a lot. A lot of people remain on treatment until they've got quite advanced disease, or the disease declares itself, which is very different to how mesothelioma was 10 years ago, even 5 years ago. And so there's often a very close relationship with the oncologist and the oncology nurse, but that isn't the case all the time. If somebody is linked to the palliative care service, it's often the palliative care nurse or the palliative care doctor that has that discussion. It could be the GP who is very involved in the care, or the care coordinator. So it's the person that is in that position. So I would always say ideally the treating team first, and depending on who else has that connection with the patient and their family to be able to have that discussion. It needs to be had well, and I think what we are doing is teaching doctors and health professionals how to communicate better. And so I think we're getting better at having those discussions, but it takes a while.
Yeah, probably on the whole I would agree with Judith. One thing I would just like to challenge though is we tend to keep using these words, active treatment, and I just wonder what that must say to a patient and a family, because the opposite of active is inactive or non-active, and I just wonder whether that really sends the wrong message. You know, I really think in our very fortunate first world country that we live in, we are supporting and managing, and if you want to use the word treat, people right through to death and after death in the support of family afterwards. And I just think we've got to really, I think, personally lose that word active, because I spend a lot of time in palliative care convincing very scared people that people aren't deserting you. Now, parallel, I think the advent of clinical trials has meant that people see that the person that perhaps gave them their fairly serious diagnosis a year ago or 10 years ago is in fact still very involved, whereas historically it used to at times only be a line in the sand and the active treatment's finished and this is now palliative care. And believe you me, as a pal care specialist, walking in and convincing people that you know, you are here to still help them live well is often a big job, and it still is at times. I think we've got a lot to say about our language still.
Okay, know? And I used it. So I'll sort of take a step back and explain. I guess I've been working with mesothelioma patients for 20 years now, a little bit longer. So I was around before Permatrexate, before Olympta, before any treatment that was helpful to modify mesothelioma was actually on the market. And I remember the first patient who received it and who went from a wheelchair and his oxygen to going off skiing and feeling fantastic because of the disease modifying capabilities even in people with advanced disease. What's happening now is that we're looking all the time to see how we can continue to up the ante and try and modify the disease to control it so that people can live as well as possible every day. And what that means in real time in advanced cancer patients, and not just in mesothelioma, but as well as in mesothelioma patients, is there are more and more clinical trials that may have an active role in modifying the disease, either stabilising it or keeping it under control for a little bit longer, or controlling it for a bit longer, including radiotherapy. And so it's an active process of modifying the disease. My recommendation is that all patients have a parallel, but the chance of that working is not as high as when you start. So it may be a 20% chance of it working, or a 30% chance, or a 10% chance. And so it's really important that people have parallel care, so they're seeing They have a team in place that keep them as well as possible every day. And if the disease-modifying therapy is helping for a period, that's great. But they still have the team there that are monitoring them, that are watching out, that are looking for symptoms and signs of disease progression and saying, okay, it looks like this isn't working, and it looks like there aren't any other options, but we're your team and we're going to keep looking after you every day, and we're going to make sure your life is as good as possible. So that's how I use the term active.
I've got a slightly different opinion again, just to make it more interesting, really. I think when you're needing some guidance on where to go, you need someone that's middle ground that can see the benefits of both sides. So see the benefit of what the oncologist is offering, and also see the benefit of what the palliative care team are offering, because they're all working together to get the best outcome for you. But there's no doubt the oncologist is trying to treat you to keep you here as long as possible in the best way possible. The palliative care team are looking at just making quality of life the biggest focus, and not necessarily including treatment. Yes, it does, but not always thinking that way. So I think the patient and family always need someone sort of sitting in the middle that can go, well, the benefits to this side are X, Y and Z, and the side effects to what they're offering, though, are X, Y and Z as well. And then get the side from, the palliative care side as well, and help you to find where the patient wants to go. Because I find that oncologists very often can lead the patient without actually listening to the patient. So you need someone that can guide you on both sides of the coins. And that might be the social worker. It might be the counselling team. I'm hoping out west, where I'm from, that it's the care coordinator that is able to, just without any bias, see the good and the bad on both sides for you and just help you to make the right decision.
And the role of care coordinator is increasingly becoming important in all cancer streams now. And it's a really important role, because you really need that person to be able to help you navigate, because it's very, very complicated. It used to be simple. And, it's great that it's complicated, but it needs to be good for the person.
So, Fran, would you like to just continue on and tell us about the priorities that you set for your country people? Obviously, country people often are thought to be disadvantaged because they live in the country. They're a long way from supposedly expert mesothelioma centres. Can you tell us about your experience with mesothelioma people in the Orange, your area, please?
Surprisingly, my experience in Orange is very, I was going to say similar to Metropolitan. We don't have cardiothoracic surgeons out in the country at all, so our patients would have to travel to get any surgery input. But other than that, we offer the same treatment options that people in the city get. So we can do the same chemotherapies. We've got access to getting funding to do the immunotherapies if they qualify for that. We've got a huge clinical trials team out in Orange. The leaders in the state 2 years ago, we got the big award. So we're right up there. But yeah, anything that requires that cardiothoracic input from the surgeon, we would have to outsource. But so much of the work that needs to be done for a meso patient can be done by a very clever interventional radiologist or by a respiratory physician. And I'm just thinking for those patients that get the fluid build up in their lungs, we don't necessarily need a cardiothoracic to manage that. We use both our respiratory physician and our interventional radiologist, and actually our palliative care physician is also very clever at putting a Pleurex drain in, which is, fantastic for quality of life for a lot of our patients. The other sort of priorities we look at, they're from further west or they're from further north or south, getting into those really remote areas of New South Wales. They're a lot more difficult to manage. There's very little in the way of transport options for patients out there, and a lot of patients will make decisions on just what's the easiest thing for their families or the easiest thing, you know, to cause as least trouble as possible. So that can be really challenging to get patients around and to convince them that they're worth making an effort for. You know, I find I've often got to remind the patient that, you know, their wives or their husband's most significant other, that their children value every minute they're here, and that they're worth fighting for. So we have to be very creative in what we can do with those very isolated country patients. There are a few things around we can use. So we use things like angel flight to get patients from A to B. That's really usually the really quite remote areas. But remote sometimes is only 4 hours away from us, which is, you know, 7 hours from Sydney, or 7 hours from 7 hours from Newcastle, or something like that. So angel flight's one of our big backstops. But we've got community transport in most of the towns across the state. They all have, you know, limits to what they can do, but very often we can con or manipulate them to take a patient, say, 2 hours, then have another team pick them up and take them another 2 hours, and so on until we get that person as close to the treatment centre as we can. There's some, am I doing that?
What's happening?
One thing I was just going to mention that I don't know if you have it down in the Sydney area, Cancer Council of New South Wales offers us transport to treatment service. We were the pilots for that out in the country actually, and we rely on that service so heavily. That's actually a free service if you qualify for it. The Cancer Council asks that you've exhausted every possible mode of transportation before you use them, because they can't guarantee to get people from A to B. But that's a fantastic service that, you know, we can't live without out there. The cost of drugs, of course, can be prohibitive for a lot of people. A lot of that GoFundMe and that sort of thing is happening now if people don't qualify for pembrolizumab, for example. You know, people are getting their communities to raise funds to let them have the drugs.
And does that mean that people who have progressive disease and are dying, are getting timely care in the best place possible through all of these connections and places in the country? Is it possible to provide the same level of care at that stage in the country because of all of your spaces as it is in the city and the metropolitan area?
I think we're definitely closing a lot of those gaps that we once had. Most things are getting slightly easier. Not everything, of course. I think transport continues to get worse. And one of the other big things, I'm not sure that there's that many mesothelioma patients that work. I think most people have to stop work. Do you agree with that? When they've got a meso diagnosis? But certainly out in the country, they have to give up their income, you know, to get help. They just can't maintain all of the travel involved in getting their treatments and seeing their specialists and maintaining jobs very often. Maybe on a permanent part-time basis, they can do well.
Oh, no minds. Maybe they just filled up.
Do you actually need the microphone? Oh, you need it for the recording?
I think certainly depends on the stage of diagnosis. Some of our folk continue to work full-time, but it does depend on how well they are, what treatment they're having, and again, how close they are to treatment centres. So it's very individual. But yeah, we do have some people who continue to work full-time and some who work part-time. So it is very much variable.
Joe, while you've got the microphone, in our role here as support people for with mesothelioma, we obviously support and in communication by telephone and email quite frequently with them. So during our contacts, or particularly with your contact with them, what cues do you pick up that things are not right, and how do you as a practitioner decide on actions, given that we're registered nurses practicing sort of aside of any particular medical team?
I think certainly for a number of people I've spoken to, and I'm sure it's the same for you, Jocelyn, you can actually hear in their voice. Their voice is changing, they're quite breathless, and in some cases they've deteriorated quite rapidly. Now these are some of our folk who are much in the latter stages of the disease, so I will do an assessment based on how they sound, what's been happening, how much more they're sleeping, and all the things that we've spoken about before: appetite, sleep, fatigue, pain. And again, it depends on who's their best port of call. Because predominantly our patients are in New South Wales, but we do have people all around Australia and some from New Zealand that make contact with us. So it's who's their best person. Now that may be the nurse consultant who comes to visit through the palliative care team, it may be their GP, it may be the community nurse. In some cases it's also some of our folk who are supported through eye care, through the dust diseases. I know that if I ring, and we always seek permission from patients before we make contact with any other service provider. And we might then contact, say, dust diseases and say, okay, things are changing, we need some equipment, they need some more support, they need an assessment. And we have on occasion contacted other palliative care services. So again, it's very individual, and it's also how comfortable the person is themselves, because sometimes some of our folk know they're dying and they want the least intervention that they possibly can. So the less people know, the better, and that creates its own problems, particularly for people who live on their own. But I always try and encourage them to have conversations with their community nurse about having care plans in place, what the issue will be if they need to be transferred to hospital, do they have an ambulance plan, what services they've got, and other services that can help them stay at home. And that might be through home care, through community services, through dust diseases, through their family connections. So that's really, I guess, what I would do, yeah.
Mm-hmm.
If I could just say one other thing, I think, in terms of the original question around, who perhaps takes the lead. For any of us that are, residents of this country or this state, we should have an expectation, so you should have an expectation that we all, as health professionals, have a level of accountability. And so I think as the patient and the carers and the families, that it's your right to be able to say to whoever you see, whether it's the Judiths or myself or the Frans or whoever, are you communicating everything to everyone else on my team of carers? Because you are too busy living life to be trying to make sure that everyone in that team knows what's going on with you. And I think it really behoves all of us that we really make clear that I will be talking to Dr. Lacey that you saw 3 weeks ago, and I know that you talked to Jocelyn on the phone. Anything that's, especially important, but as an all-round. Now, it sounds a bit Pollyanna perfection, but I do think that's what we should all be aiming towards doing. And unfortunately, if we had one, electronic health record in the state, we would manage that a lot better, but we still have private providers in this space. So, in time, maybe long after I'm gone, I'm sure we might get there. But I do think that that's your right to say to whoever's seeing you at home or in the hospital, you know, have you spoken to such and such? And the last thing I would say is, as people's condition is deteriorating, that the effort to get out of home into hospital settings for appointments is obviously reduced. So I think there's got to be a huge amount of respect for the GP, the community nurse, the community PAL care team, that, you know, they are often going to be the main people, you know, and a great GP is obviously the absolute kingpin to a lot of things, but we know that the world of GP land is changing to some degree, and so we don't have the amount of GPs at home visit anymore. So that's another sort of challenge that we can face.
I think even following our discussion now, everybody's got a slightly different take on things. So it's really important that, you know, for me with my patients, when I have a discussion about potentially stopping treatment, it's not improved, your quality of life's really bad, you're getting a lot of side effects, having those discussions to then either ring the oncologist and the palliative care team, or to send emails or to send letters to make sure that everyone is actually on the same page, giving the same information, and check in. It's my responsibility as a doctor to check in, because otherwise people are getting different messages from different people, and that's not good for anybody's well-being and health. We may disagree, and we may say, I may say to the oncologist, let's have a conversation about it. I'm old enough to do that now, but it is really important to feel comfortable and confident with your treating team that they are responsible and are communicating so that you're getting the same message and not mixed messages, and that it's a consensus decision opposite sometimes.
Can we move on now to the next difficult, well, it's difficult, it's a challenging question, but it's, you know, we all know the joy of a baby arriving in this world, but yet we are quite afraid to talk about or want to feel the experience, the feelings associated with losing someone who has died. So how do we know when somebody is approaching dying, and what do we say to the people, the patients, the families? We've got 5 minutes.
We've got 5 minutes left.
5 minutes left.
Oh,
sorry.
okay.
So, we've got 5.
Okay. I'm very lucky. I guess I'm lucky. I don't know if I'm lucky. I wrote the chapter for the last days of life for the Oxford textbook of medicine, in palliative medicine, for 2015. I've just reviewed it again and rewritten it for 2020. And in doing that, it makes you think, well, what do we do and what do we teach other health professionals in how to approach that time of dying? I think the most important thing is to be prepared, and that the team is prepared, and that you trust that the team are prepared, because it's not rocket science to keep someone comfortable, but it takes an effort. It takes time to say the right things by the bedside, to recognise symptoms, to get rid of non-essential drugs, to have all the right drugs in the house so that pain and breathlessness and anxiety and distress is well controlled. It's also really important that everybody is on the same page, and the resuscitation order's been done and those discussions have been had. And it's a step-by-step process, and making sure that you know that your loved one is going to be cared for and have a death with dignity in the place they want to be, if possible, and dying with the people around them who are well informed and well supported at that time. And it's having the knowledge and checking in, and I often check in with my patients. They'll often say to me, you know, what's it going to be like at the end of life? Just let me know, tell me now, even though it's going to be maybe in 6 months' time or a few months' time. And going through what it will be like as somebody's dying, how as they are unable to eat, how we deliver mouth care, how we change our approach to care. If they need a catheter, if they're agitated, what do we do? If they've got pain, what do we do? And it's going through that process with people that is actually, I find, puts people at peace to know that at the time your loved one will be treated with the utmost dignity, and the most important thing is they maintain their sense of dignity. Predicting when that comes, we're not good until about the last month of life. We're really good at the last week and fantastic at the last few days. So we're not, and that's where it's, but we're good at preparing and being ready and having that first aid kit available. So it's really knowing that your team know what to do, and my role has been to educate people as to what to do, so I don't have to do it all the time, but it's, and it may be your GP that is the person that is managing that at the end of life, maybe at home, and it may be in choosing that place. And so that's a part of the process, but there's also the bereavement and the anticipating that you're losing somebody, and how our counsellors are trained to support you through that, and how what happens afterwards, knowing that for you your loved ones are going to be cared for in a year and in 2 years' time, and there's really good bereavement services, and they're not going to be abandoned, because that's part of the service as well. And so that's part of the whole, I guess, what we're trying to.
Absolutely ditto everything that Judith has said. One really often unspoken thing that I think we always should unpack with people is when they're feeling comfortable to talk about, what dying does look like, because for many people in life, they've never seen anyone die. But there are also many people who've had experience with someone dying and it was not a good experience. Now, none of us are sitting here saying that death is a good experience overall, but people have often had fairly poor traumatic experiences, and say for people of most of our generation here, we may have the memory of an older relative who died fairly poorly, with symptoms not managed well, and my experience has often been, if we can, find out, have you ever, I just ask people, have you ever had anyone in your life die, and ask them how that went, and by just, talking through that and trying to reassure people, and I don't think any of us say that we can guarantee you anything in perfection, because the human soul and the human body, is different everywhere. But I think understanding what people perhaps have already experienced does go a long way to giving them some confidence, and then for us to reassure that we, try to do absolutely everything possible to give people that, confident, dignified experience for everyone, and afterwards, after that person's died. I think Jocelyn mentioned around ambulance care plans. They've been a huge plus, I think, for people dying at home. We know that in this state we believe a lot of people would choose to die at home, but we know in reality that that's not always, people with a single carer, we know that's always a bit of a harder, many people achieve it, but, many hands can make light work. But having paramedics that can come and see that there is a clear plan outlined, that patient and carer's wishes are clearly documented on a piece of paper. So when that carer, you're really distressed and you're tired and you're fatigued and you can't quite get out exactly, everything's there, should be there in the house, on the fridge. I think that's been a big plus in our care of people dying well at home.
Just one thing, or maybe two, that I wanted to add. Very often it's the patient that recognises they're dying and they will tell us. Other times it's the health professional, but very often the patient is the one that tells us. And of course, thoroughly agree with the other two girls, everything that they've said. You just need impeccable support at that time. And I'm a big believer in plans. I always like to give people a plan. If, and it's more for the carers at this point, it's reassurance for the patient, but a plan for the carer. If your person gets pain, we do this first, then we do that second, we do that third. And the same with every symptom that they can possibly go through, just to give them a plan so that they know exactly what's happening and what to do.
The only other thing I'd like to add, and I agree with everything that's been said, is that for people who really want to die at home, or for their loved ones who really want the person to die at home, that everyone's entitled to change their mind. And sometimes circumstances and it's not through lack of love or care or support or teamwork, that things just have to change. It may be within, not ideally, but within hours of death, or within the last couple of days prior to death, that sometimes people need to go to hospital. And I think everyone needs to be assured that that's okay. Changing your mind as to place because of circumstances or because you've just changed your mind. And that can even be as the person who's dying. You may say, you know what, I thought I was ready to do this at home. I'm not. I need to go to hospital. And that is absolutely okay.
Wow, what an interesting conversation. So I want to just say thank you to our panel, Joanne, Judith, Fran and Therese. And I just want to conclude with a few words. It says, and it's from this beautiful little booklet. It's a children's booklet called Beginnings and Endings. And it says, there is a beginning and an ending to everything that is alive. In between is a lifetime. Dying is much a part of living as being born. So thank you for your attention and thank you.